Good afternoon and welcome to Pathways webinar brought to you by Aspire Labs, a Vermilion company. My name is Keontae Key. I'm the Digital Customer Experience Manager for Aspire Labs and moderator for today's chat. Our team will walk you through the new changes to the OVA1 results report along with the case study. Anytime during the webinar you might have a question, you can use our Q&A feature, and we can ask the question live, or if we don't have any time, we'll email you. Also keep in mind this webinar is being recorded, so if you have a colleague that didn't make it or you want to go back and listen to the case study and the new changes again, you'll receive a link to the video after the webinar is over. So I'm going to go ahead and hand it over to Dr. Francis and Dr. Fritchie.
Hi, everybody. My name is Dr. Mara Francis. I'm a gynecologist in San Antonio, and I'm the new Chief Medical Officer for Vermilion Laboratories.
And I am Herb Fritchie. I am the Laboratory Director for Aspire Labs. So we do the testing and send the reports out to you.
Okay, I think we'll go to the next slide. This is just an overview of the clinical application of OVA1 and where you would use it in your clinical practice. Obviously, if you have an adnexal mass, there's many variables that you're going to be looking at before you decide what is going to be the best care pathway. You're going to have patients' history, symptoms, any risk factors that they may be increased because of family history, your ultrasound reports, your physical exam, and then OVA1 is really just another tool to help you better define risk of malignancy. If you have a low risk OVA1 score, then you are confident in knowing that you can manage that patient yourself, and you do not need to refer that patient out. If you have an elevated risk OVA1 score, then that just helps you better prepare for the surgery, whether that means having your GYN oncologist be on call for you, or referring the patient outright. And obviously, if you're going to do the surgery and have your GYN oncologist on call for you, making sure you have a pathologist to do a frozen section available. We can go on to the next slide. So this is what the new OVA1 report looks like. And over the next two slides, we're going to kind of break down the new features. But your score for your OVA1 is sort of in the top left in that box inside the box. And you'll have the score, and it will tell you whether or not it is elevated or a low risk score right there. We could go to the next slide. And you can see that the CA-125 level is separated out for you now. We felt that this was important, especially for the patients who go on to be diagnosed with a malignancy. You have an early baseline CA-125 level to provide to the oncologist from early onset of the disease. And furthermore, it may just be something that you were interested in to see, what you might have missed with the CA-125 that the OVA1 actually picked up for you. And we can go to the next slide. And what we've added and what we're going to really discuss today is called the Goodrich graph. This graph actually links the OVA1 score with ultrasound findings and gives you a risk of malignancy percentage. This is incredibly important, especially for patients who may have an ultrasound that is not completely normal looking, but also not very high risk for cancer looking. We all have radiologists who say might include but cannot be limited to, and you have just a whole lot of words and not really anything definitive. But you can use your ultrasound findings and your OVA1 score to actually get a risk of malignancy that you could tell the patient, this is the likelihood that this may be a cancer, and then you can appropriately plan their surgery. If you go on to the next slide. So this is our case study for today. This is a 41-year-old P3 with right-sided pelvic pain. A mass was palpated on exam and an ultrasound revealed a slightly enlarged ovary. The cyst is not that impressive. It's 3.3 by 3.9 centimeters in size, and there's a small amount of tissue along the medial margin of the cyst, and it only measures 5 millimeters. Again, you may have a radiologist that calls this a papillary projection, and then that would make you think that this is a higher risk finding. You may have a radiologist that may say that this could possibly be a clot from a hemorrhagic cyst that's resolving, and then that would put this more as a lower risk ultrasound. So in this case, the ultrasound may or may not have given you a whole lot more information to decide how to manage the patient. You can go to the next slide. However, with your OVA1 score, she has a very elevated risk. Her risk is 9.4. So right away, you know that this is probably not going to just be a benign cyst. Her CA125 level, interestingly, is normal. Had you only ordered a CA125 on this patient, you might have just taken her for a cystectomy. Based on her age, you may have taken her for an oophorectomy. But you probably, with that CA125 level, would have not asked your GYN oncologist to be on call for you or had gotten a frozen section. If you plotted her score, however, on the Goodrich graph, and even if you thought that the ultrasound was low risk, which is the bottom curve because she's premenopausal, but you said maybe it's high risk, and then you looked at the curve right above that, which is high risk for premenopausal, with a score of 9.4, her risk of malignancy is somewhere between about 40 and 70%. So about 40% if you consider it a low-risk ultrasound finding, and about 70% if you consider it a high-risk ultrasound finding. So then that can help you further decide how you're going to prepare for that surgery. And in this instance, the provider prepared for the surgery with the GYN oncologist on backup. Frozen section was done. The GYN oncologist came in and completed the surgery because the patient was actually found to have a papillary serous borderline tumor of the ovary. So again, the graph is just another tool to help you better assess what you may be dealing with before you go to the OR, because nobody likes to be surprised. It can give you an opportunity to refer a patient outright to a GYN oncologist or prepare to have the GYN oncologist available to you. And once again, just to point out that in this particular case, the CA125 alone, you would have been unprepared for the diagnosis that the patient had ultimately received. And we can go on. And I believe we're going to turn it over to Dr. Fritchie at this point.
Thank you, Mara. I think I would just add to Mara's presentation information that is shown in the box down below versus OVA1 values, where those risks are now calculated for you based on the data in the graph above, which shows the pre- and postmenopausal lines with and without abnormal ultrasound. So those, instead of just saying, as we have in the past, the risk is high risk or low risk, we actually are now reporting a percent risk based on the Goodrich data. The other thing I'd emphasize is that I am available at any time to discuss any abnormal results or to provide you with more information about the OVA1 test. You can reach me through the telephone number there that's listed on the right side of the graph. And I'm available to take your call at any time, so feel free to give me a call if you've got any questions at all. Thank you.
I think we are going to go to the question and answer section right now. So if anyone has a question that they would like to send in, we can answer any questions you have now, and obviously you'll be able to email us any questions you think of in the future as well.
Okay, so one question we have, why did we change the report?
The report was changed because we felt that the more information that we could provide to better define a risk of malignancy before a surgery was completed, then that just gives a better outcome for the patient. Obviously, for those who are high risk for malignancy, because it is best for them to have a single surgery and the first surgery with a GYN oncologist available or just outright. But it also really helps the provider. It's going to be able to give you a lot more information with regards to your informed consent preoperatively, and gives the patient a realistic expectation of what diagnosis they may be dealing with.
Okay, and another question, why is OVA1 better than using CA125 ultrasound?
So CA125 will only give you an elevated result if you have a serous carcinoma. So not all ovarian cancers are serous, they're not all epithelial cell ovarian carcinomas. So you're going to miss your mucinous carcinomas, you're going to miss your borderline carcinomas, and you're going to miss any of your other ovarian cancers like your sex cord stromal, or some of your more very rare ovarian cancers. But basically, OVA1 will identify all 5 subtypes of ovarian cancer. CA125 will only identify 1. So you're going to not miss cancers is the number one reason. Number two is CA125 is extremely unreliable in premenopausal women. And you will potentially miss cancers or overdiagnose cancers that are benign conditions in premenopausal women. Oh, in early stage, yes. So OVA1 is the only biomarker test that increases the likelihood of finding an ovarian cancer at the earliest stage possible.
Great. So with the new report, how will physicians receive the new report?
The same way that you did before, it will be faxed to you, and reports are usually available within 24 to 48 hours of the sample being sent in.
Great. And final question, when will the report be available?
We are in the final processes of approval and implementation in our LIS system. We think the reports will be available as early as next week.
Thank you. That concludes our Q&A. We want to thank you all so much for participating in the Pathways webinar. To learn more about changes to the new OVA1 results report, you can set up time to speak with your sales rep. You can also email marketing@vermilion.com about questions or supporting materials. You can also schedule time with Dr. Francis or Dr. Fritchie by emailing them directly. And lastly, you can join our next webinar on December 14th. We'll be talking about, the focus is interpreting cutoff ranges on the new OVA1 results report, and we'll have 2 case studies that Dr. Fritchie and Dr. Francis will review. And if we weren't able to get to your question, we will email you and get the answers that you need. Again, this was recorded, and you will be able to view this later and share with your colleagues. Thank you so much for participating.